Hi everyone, this is Paul Pereira, Vice President of Patient Advocacy at Seniona. And on behalf of our entire team, we're proud to sponsor the 2021 Pituitary Brain Tumor Virtual Family Conference. We are extremely grateful to the hypothalamic obesity community for all of your stories and insights as they've helped shape who we are as a company and our drug development efforts. And we're excited to continue to learn more from you throughout the course of this conference. For more information, please visit our website at seniona.com or hypothalamicstudy.com. Thank you.
As a nuclear engineer at the University of Michigan, which is, I guess, how he started to acquire the many skills in physics that one needs to pursue a clinical training and research training in radiation oncology. His training has taken him all over the country, all over the world, Chicago, France, the Netherlands. He's been on staff at Memorial Sloan Kettering. He's trained at Massachusetts Eye and Boston Children's Hospital. Really an incredible scope of training and research. And he studies what he's going to be sharing with us today, application of advanced radiotherapy methods. And he's particularly focused on brain tumors, hoping to increase cure rates and also reduce or eliminate the side effects of radiation. And I'm looking forward to his talk for all sorts of reasons, but two most important. First, I always welcome the opportunity to learn more about radiation therapy itself, the details of how it's delivered. It's come so far, even since my training. And then I think Dr. Merchant's group has been really amazing in examining holistically the effects of tumors and treatment on their patients, looking at all sorts of different dimensions that are really important to patients. So I'm really excited that we get to hear from him today. So I'll turn it over to you, Dr. Merchant.
Well, thank you very much, Dr. McCormick. I'm going to go ahead and share my screen and hope that everybody can see this now.
And we sure can. Thanks.
Good. So I really appreciate the opportunity to participate in this conference today and represent my department and institution. I've been asked to speak about craniopharyngioma, and I've chosen the long-term outcomes for children treated on the St. Jude RT1 protocol. And this was the first protocol for conformal radiation therapy for children with localized brain tumors. I was interested in the comments of Dr. McCormick earlier about our publication history and track record. I really think that we have so much to offer, and I hope in the next couple of years we'll be able to get these results out to you. So I'm going to talk today about limited surgery and conformal photon radiation therapy for pediatric craniopharyngioma and the long-term results. And I'm going to go back to the beginning of my slides and show here that this is really the long-term outcomes of the RT1 protocol for craniopharyngioma. So I'd like to introduce St. Jude Children's Research Hospital to you. We have several experiences here with craniopharyngioma. I'm going to focus on the cohort that was treated all the way back to 1997 and 1998, not too long after I came to St. Jude. And we're going to go over the results of the RT1 protocol, which are fairly comprehensive in terms of outcomes for children treated with early radiotherapy methods. So to talk about St. Jude briefly, St. Jude was opened in 1962, was founded by the entertainer Danny Thomas. Its focus has always been pediatric catastrophic diseases. The early history was its work on leukemia. This is where leukemia was first cured in children in the late 1960s and early 70s. In fact, radiotherapy has an important role to play in the cure of leukemia. As far as pediatric oncology, St. Jude admits about 600 new cancer patients each year. The requirement for admission is that a child fits a clinical protocol. Unfortunately, we've been able to offer a series of clinical trials for craniopharyngioma at St. Jude. Patients are treated at St. Jude regardless of their ability to pay, and we provide housing and travel and so forth for both treatment and follow-up. So St. Jude is located in Memphis, Tennessee, which is in the Mid-South of the United States. There are 8 regional affiliates, and these affiliates send patients to us and also provide ongoing care, especially for children who are treated on clinical trials. We have the St. Jude Red Frog Events Proton Therapy Center. This is a proton therapy center that was designed solely to the treatment of children with cancer, and it was opened 6 years ago. We've already treated more than 1,000 patients. In the specialty of radiation oncology, not only is the beam important, but also medical imaging. And over the course of the past 25 or so years, we've been using CT scans and MRIs to plan treatment. And that's allowed us to focus the radiation very carefully on the target, especially for children with craniopharyngioma. So at St. Jude, we have radiation oncologists and a pretty large treatment team. This includes radiation therapists that are involved in the treatment of the patients. We have medical physicists and dosimetrists, and they do the radiation dose calculations and help us to plan treatment. Obviously, we have nursing, physicians, board-certified radiation oncologists, and a cadre of researchers that support our efforts. Institutionally, it's very important to have child life involved in the treatment and evaluation of our patients. We have great anesthesia support with both physicians, certified nurse practitioners, and anesthesia support. We also have a cadre of engineers that are involved in maintaining our equipment. So it's really a big operation to provide radiotherapy to children. If you look at our practice in pediatric radiation oncology, it's largely focused on brain tumors. And curiously, in our practice, craniopharyngioma is the 3rd most common tumor that we treat behind medulloblastoma and ependymoma. And that's because we've been able to offer protocols using radiotherapy for children and have been successful in recruiting children to Memphis for treatment on our studies. Craniopharyngioma in general in North America, we see that in the US, there are about 160 cases in children under the age of 21 years. Put these numbers here for Canada, which is about 1/10 of the size of the US in terms of population. So obviously craniopharyngioma is a very rare tumor. There are no cooperative group trials that include radiation therapy because it is so rare. Children in the US and Canada are now referred for proton therapy, which is the newer form of radiation therapy. Although I learned that in Canada, generally the kids under 13 are the ones who are eligible. So craniopharyngioma is certainly a benign neoplasm. It's the most common non-glial brain tumor in children. It arises, as you know, along the craniopharyngeal duct. It's uniformly the adamantinomatous histologic subtype. It's cystic and solid with frequent fluctuations, and this really impacts how we deliver radiotherapy. It is locally aggressive, inherent, and sometimes invasive, and this can impact the complications from surgery, but also radiotherapy. Presentation often includes compression neurovascular structures, obstructive hydrocephalus, and these things need to be dealt with before radiotherapy is administered. In our series, and in most series, the median age is about 8 years. The location is always suprasellar. There's a high incidence of tumor-related morbidity, and we recognize that in evaluating and planning children for radiotherapy, and that includes vision loss or endocrinopathy. When we look at the treatment options for patients with craniopharyngioma, we do consider radical surgery, but more often we provide limited surgery and radiation therapy to 54 gray, which is generally 30 fractions over the course of 6 weeks. Our expectation is that the event-free survival at 10 years is about 85%, and this is what we tell families. So because craniopharyngioma lacks biological and molecular features amenable to systemic therapy, surgery and radiation therapy are the mainstays. We recognize that gross total resection is a good treatment if you can get every cell out without hurting the patient. but it is associated with panhypopituitarism, diabetes insipidus, and occasionally hypothalamic injury. We prefer limited resection and adjuvant radiation therapy because it provides equivalent overall survival, and we think it can reduce some of the treatment-related morbidity. We go back to the benchmark protocol that was carried out at the Royal Marsden Hospital in England back in the 1950s and 1960s, where radiotherapy was used in conjunction with limited surgery to achieve high rates of progression-free survival. And these benchmarks have remained consistently the same. And so our focus in designing treatments has really been to limit the side effects of treatment, maybe not improve disease control. There have been a number of publications comparing surgery and surgery plus radiation therapy. The bottom line here is that the progression-free survival for surgery and radiotherapy might be slightly different, favoring radiotherapy, but those patients who have gross total resection or attempted resection, when they progress, can go on to receive radiotherapy and have equivalent outcomes in terms of overall survival. We always look at the toxicity profile comparing radical surgery to radiotherapy. The big difference in terms of acute effects would be diabetes insipidus that's more often seen in patients treated with radical surgery. From a chronic condition standpoint, we've seen reduced performance status in our patients who've been treated with surgery, but there are chronic concerns, vasculopathy, secondary tumors, and potentially necrosis after radiotherapy that we're always concerned about. So when we look at the St. Jude experience, going back to more conventional radiation therapy, prior to my arrival at St. Jude, about 25 to 30 patients were treated with more conventional radiation therapy. We instituted the RT1 protocol in the late 1990s, and this included conformal or intensity modulated radiation therapy, where more than 100 children were treated over a period of time. And then finally, we had a series of patients. This was called the RT2 protocol, which was carried out in conjunction with the University of Florida, which used first generation proton therapy. And then now since 2016, and the advent of the St. Jude Red Frog Events Proton Therapy Center, just over the past 6 years or so, we've treated more than 100 children, 120 children using proton therapy. After I came to St. Jude, I looked at the initial experience of patients treated here, those treated with both surgery and combined modality therapy with surgery and radiation therapy. And the big difference was the performance IQ in these patients. The overall verbal IQ and full skills IQ really didn't differ much between those treated with surgery and radiation therapy, but it was that difference in performance status. And so we sought to increase the number of patients on our protocols treated using combined approach with limited surgery and radiation therapy. And so the RT1 protocol was born in the late 1990s, and that was our first attempt to implement conformal radiation therapy for children with localized brain tumors. And when we designed the study, we didn't really know who would come. We allowed patients with tumors that were localized, meaning patients with tumors like medulloblastoma would not be eligible because those require craniospinal irradiation. And after a period of time, we had 4 groups of patients. We had those with craniopharyngioma, low-grade glioma, ependymoma, and high-grade glioma. And so we published on all these, both in preliminary and long-term outcomes for these tumors. And we're going to focus on craniopharyngioma today. So in our early write-up of the RT1, and this was back in 2013, we looked at conformal and intensity modulated photon therapy for a period of time. And we found some very important prognostic factors. One was the impact of race on outcome. The other was the impact of CSF shunt. The other was that there was no difference whether we treated with a very limited or larger clinical target volume margin. That's the margin surrounding the postoperative tumor bed and or residual tumor. And we also found that when we deliver radiotherapy, the number of imaging studies that we do during treatment to make sure that we're aligned, our beam is aligned to the target, the number of imaging studies was associated with improved disease control. And so obviously the demographics, these would be a hospital located in the Mid-South. Maybe it's not the same in other parts of the country. The CSF shunting variable for disease control outcome was seen in prior neurosurgical series, so that was not new. And then the finding that imaging was important during treatment is all about precision targeting during radiotherapy. So during the past year, we've looked at longer-term results of the RT1 cohort. Scilla Edmiston is a resident at the University of Tennessee Health Science Center, and she worked with me over the past year to look at the long-term outcomes from this RT1 cohort. Very interesting that all the patients have been followed at least 10 years, and the median follow-up is in the neighborhood of 15 years. And she presented the results from this study just a few weeks ago at our international society called American Society of Therapeutic Radiation Oncology. When we look at the children who are treated with the early experience with RT1, when I put this slide together for you this week, I found the very first patient who was treated on the study, and you can see this on the left with a larger margin. This patient, she obviously had a larger tumor. On the right-hand side, the last patient that we treated, obviously someone who was diagnosed very early, much smaller tumor in a more limited clinical target volume margin. In our series, though, all patients received 54 gray. There were 7 that had 55.8 gray. Most of our patients are referred from outside facilities after limited surgery or prior radical surgery and then progression. So there's really not a whole lot that we can do from a surgical standpoint unless the patient's newly diagnosed and referred to us. And we follow these patients very carefully early after radiotherapy, every 6 months, then through 5 years, and then annually through year 10 in our department. And as I mentioned, the median follow-up from our radiotherapy series here is now 15 years, ranging up to 10 to 21 years. When we look at our patients from a demographic standpoint, most of them presented with headaches, other things like visual disturbance, endocrinopathies were also common. There are also patients who were diagnosed based on head trauma who were found to have craniopharyngioma, observed for a brief period of time, and then irradiated. Distribution of patient demographics as shown here on the right. And when we look at the number of patients in our series, out of 101, 27 were shunted. That's probably more than you'd see in a more modern series of surgeons have learned to remove the blockage of the ventricular system surgically and avoid putting in VP shunts. In radiation planning dosimetry, we had a distribution of target volumes. We had an early patient group that had a 1 centimeter clinical target volume margin, a later group with a 0.5 cm clinical target volume margin. And we have really detailed dose data for all these patients. And this is very important information because we can associate it with long-term outcomes. As far as surgery in the RT1 cohort, more than 197 tumor-directed surgical procedures were performed on these 101 patients, not including those that had post-treatment catheter placement, cyst aspiration, CSF diversion, and other surgical procedures. So while we say limited surgery in radiation therapy, there's a tremendous amount of surgery that takes place for these patients, even on a limited basis. So these are the important results from the study. We're looking at progression-free, event-free, and overall survival in the 10-year estimates. So progression-free survival is tumor progression. And so at 10 years, progression-free survival is in the range of 80%, and that's what we would expect. Event-free survival and event-free survival is affected not just by tumor progression, but someone could die from another cause. That could be an accident, that could be a secondary tumor. And then the nice thing about this series is that the overall survival is 96% at 10 years. And I think this is an important number for patients and parents to see. 20 patients had tumor progression out of 101 in our study. The median time to progression was 5 years. And so while we follow patients very closely early on, it's not until the later years that we really observe tumor progression after radiation therapy. 12 patients died, 6 from tumor progression, and another 6 related to complications from tumor or treatment. And there were no marginal failures, which means that when we administered radiotherapy in this group, if the tumor came back, it came back within the high dose volume. So when we look at progression-free survival, and remembering what I showed you before from our preliminary report on the RT1 protocol, both race and shunt status play an important role. Black patients have a lower progression-free survival at approximately 62% compared to white at 82%. This is something we need to look at carefully because everything else was the same. Shunt status, those who are shunted have a lower progression-free survival, also 65% compared to 83%. When we look at event-free survival, there's no impact of race, but there is an impact on shunt, meaning patients who have shunts have more events or potentially complications related to their treatment and follow-up. And then finally, when we look at overall survival, there is a difference based on race and shunt status. And again, we need to look at this very carefully. Cox hazard model, this is a statistical model to look at the potential prognostic factors. And one of the things that we found here was not only that race and shunt status were important, but also that the volume of tumor. And we've long believed that the amount of tumor that we've treated with radiotherapy, the tumor volume didn't really matter. And here, that's not the case. So does this mean that we need to do surgery on our patients to reduce the amount of tumor that's present? Is there something else going on here? Is there an association between tumor volume and shunt status and other factors? All these things need to be looked at carefully. We did not see an association between race and shunt status or tumor volume. So obviously there's something different here that we need to look at very carefully. As far as salvage therapy was successful in 13 patients, given various combinations of surgery and radiosurgery. If the tumor is difficult to remove the first time, it's certainly going to be more difficult to remove after radiotherapy, and this shows that. We did have patients who died not only from progressive disease, but also from secondary tumors. And it's important to know that no patient achieved durable tumor control with any type of systemic or intracystic therapy that was administered as a part of salvage treatment. When we look at death not associated with disease progression, we had one patient who died of an opportunistic infection. This is why hormone replacement therapy is so important. We had two patients who died of cerebrovascular disease. Obviously, there's some risk factors there. One died of a malignant brain tumor, and another died of what was called malignant craniopharyngioma. So I'd like to talk in the time that remains about complications of radiotherapy that we've observed on RT1. This is really a valuable data set because it starts out with 100 patients. The follow-up is long-term. The patients were consistently treated and followed at a single institution. So we're going to look at vasculopathy, necrosis, permanent neurologic conditions, secondary tumors. We can skip hearing because hearing loss is so rare in these patients. Visual problems, endocrinopathy, cognitive, and a little bit of social attainment. When we look at vasculopathy after radiotherapy, this is something that we follow very carefully. MR angiograms are performed at baseline in all patients and typically annually afterward. Once we see an abnormal angiogram, we tend to do that with every MRI exam. And from the start of radiation therapy to abnormal MR angiogram, if we were to see it, it's usually within the first 2 years. In our series, there were 15 cases that were abnormal within 12 months, 22 cases in 22 months, and 31 cases within 60 months. Now, MR angiography is really a screening test, it's not a gold standard test. So when we say it's abnormal, there's some subjectivity there. Obviously, if a child is dehydrated or there's some other physiologic issue, this could impact the MR angiogram. Those patients who go on to a cerebral angiogram, which is a much more invasive but gold standard procedure, this was performed in a series of patients, and only 9 of the 100 patients had abnormal cerebral angiograms. And revascularization surgery was required only in 3 patients. And this is because while they had blood vessel narrowing or even a blockage, it was compensated in most patients. 23 patients in our series were treated with aspirin. So I think it's better to look at this slide here because we have the incidence. What's the incidence at 10 years of having an abnormal cerebral angiogram? It's really less than 10%. And then the important finding here with long-term follow-up is that females had a higher rate of abnormal cerebral angiogram than males. And so this is something that we need to look at very carefully. And I think Dr. McCormick alluded to this in her talk, talking about vasculopathy and some of the risk factors and things that we need to look at here. And this could be anywhere from the patient themselves or hormone replacements, or you saw in one of the slides that she presented that surgery can impact the incidence of vasculopathy in patients treated for craniopharyngioma. And the other parameter that we found is that the target volume margin also impacted. And so the volume that we deliver radiation to has a big impact on vasculopathy after radiotherapy. And so this behooves us to treat the smallest volume possible and use the most advanced techniques. CNS necrosis. Necrosis is breakdown of normal brain tissue. Typically, we only see that in predisposing conditions, and this might be a patient who has an underlying medical cause like diabetes mellitus, or someone who's had surgical injury, and then you add a high dose of radiation. So the incidence is very low, and 10-year incidence in our series is less than 2%. And both the patients in our series who developed necrosis were successfully treated with hyperbaric oxygen. And so you can see here on our slide, not sure if I can show it here, but the brainstem here has necrosis, and this is abnormal enhancement. It shouldn't be in the brain parenchyma, and 10 years later, this patient is completely healed. So we can successfully treat necrosis. Looking at neurologic and neuropsychologic sequelae in patients, and I saw a few questions that came up in the chat today, and I know that patients and parents are very interested in this. So long-term neurologic complications, we see psychologic complications, hypersomnia, attention deficit disorder, anxiety and depression, headaches, seizure disorders. Quite a few patients are on stimulants or long-term migraine medications or long-term anticonvulsants. This may not be specifically an effect of radiotherapy, but just an effect of craniopharyngioma, location of tumor, the impact of tumor, and treatment, including surgery and radiotherapy. And then we also see what is sort of a basket diagnosis, autonomic dysfunction. 4 instances in our patients who have neurocardiogenic syncope, temperature dysregulation, and cyclic vomiting. The incidence of permanent neurologic conditions in this RT1 cohort was only 6% at 10 years. And these are unrelated to vasculopathy or necrosis. Seizure disorders, this was a bit of a surprise to me. The high incidence of seizure disorders in these patients, up to 13% at 10 years. About 20 of the 100 patients were on some type of anti-seizure medication over the course of time. This is something that we need to monitor carefully because it can affect both the performance and medical status of the patient. Secondary tumors, this is something that all patients are concerned about, and certainly parents. Those attributed to radiation therapy, there were 2 instances of high-grade glioma, and these are tumors that just cannot be cured. Meningioma, these are typically benign, slow-growing tumors that occur in the very low dose volume regions. We had 2 instances of that, malignant craniopharyngioma and papillary thyroid cancer. These days, when we administer treatment using proton therapy, there's very little, if no, scatter radiation to the thyroid. And so the incidence of thyroid cancer we know is going to go down over time. And then we had a few instances of tumors that were not attributed to radiation therapy. And these are patients who had predisposing conditions. One developed osteosarcoma and the other had acoustic neuroma, and they had a history of neurofibromatosis. So the 10-year cumulative incidence of secondary tumor is about 2%, but malignant tumor, it's 1%. So these are statistics that we're able to tell patients and parents at the time of radiation planning. Here's just some curves here to show these types of tumors. So from a vision perspective, craniopharyngioma, obviously patients present with visual disturbances, either as a part of the presenting symptoms or things that they can develop over time. In our series of patients, we see that 53 of the patients, or 52%, had normal visual acuity and normal visual field. The remaining patients had some type of visual abnormality, and that could either be an abnormality in visual field or in acuity. And so when we follow these patients over time and look at change from visual acuity, normal visual acuity and field, The 10-year cumulative incidence of change in acuity, that would be the sharpness of vision, is about 5%. So it's pretty low, but visual acuity, visual field change is much higher, and in this instance, 16%. Now, we believe this is an overestimation because you can imagine very young children cannot undergo the automated type testing. And so we have to rely on the confrontational testing, and our ophthalmologists are excellent. But once the patient's able to do automated testing, this is where we can uncover often peripheral visual field deficits, and it's probably not a new finding. We also look at change in acuity over time, and really the upshot of this, and we've done 2,000 vision exams on this 100 patient cohort. Normal eyes stay normal in terms of acuity, and although there was a significant change if you randomly choose right eye versus left eye here, the change in acuity, the acuity is still within the range of normal. And patients who have abnormal visual acuity and abnormal field, their vision stays the same. And finally, patients who have poor vision, the bad eye stays bad and the good eye stays bad. So I think that using the doses that we administer with radiation therapy, they're generally accepted as safe, and I think we've proven that over time. Endocrinopathy, obviously, is something everyone's very interested in looking at. The hypothalamic pituitary axis is at the center of the targeted volume when planning radiation. It's unavoidable that patients are going to develop endocrinopathies after radiation. But if we understand the rate at which they develop them, can we use this information to benefit the patients? And you saw in Dr. McCormick's talk today how important it is to institute hormone replacement therapy, and the duration can have a major impact on health. So we did screening testing, as anyone would do at any center, but we also have this important information, the clinical variables, the radiotherapy parameters, and other things. And we use competing risk analysis to look at the incidence of hormone replacement therapy or endocrinopathy. And so here in the RT1 series, 54 of the patients had diabetes insipidus before radiation therapy. The majority of instances were surgically induced. There were a few patients who had diabetes insipidus at presentation. It's very rare to develop DI after radiotherapy. Usually these are patients who have some transient diabetes insipidus going into treatment, or when they have cystic progression, this can injure the pituitary stalk and result in diabetes insipidus. Growth hormone deficiency, very high rate of growth hormone deficiency. As you can imagine, this is one of the most sensitive endocrinopathies to high dose radiation. In our series, white patients had a higher incidence of endocrinopathy. The question is, what do you do with this information? Growth hormone replacement, the same thing. The cumulative incidence of replacement in all patients was about 75%. So we can tell parents and caregivers when they come to treatment that we understand the incidence and time to onset of this type of hormone deficiency. The other ones are also very important. We look at thyroid hormone deficiency. There is a difference in shunted patients and those who have diabetes insipidus acquired at surgery. This is important information because here we have the ability potentially in how we surgically manage hydrocephalus to change the incidence or trajectory of this hormone replacement. Adrenal hormone deficiency and replacement. We see here that also management of hydrocephalus can have some impact on the incidence of this endocrinopathy. And also there's an association here with diabetes insipidus acquired at surgery. Precocious puberty in our series is low at about 10% at 10 years. Again, patients without DI for some reason have a higher incidence. Gonadotropin deficiency, this is something that most parents are not tuned into initially because it's not something that has to be immediately treated early on, and we can't diagnose it until the child is older. And so when we looked at our series here at the age of the patient at the time of radiotherapy, you can see the incidence is quite a bit different. And it's also impacted by a number of clinical and treatment factors. So in endocrinopathy, as mentioned by Dr. McCormick, early surveillance for panhypopituitarism is really an important thing to consider. We also prefer to limit surgery to minimize the impact of surgery and the development of diabetes insipidus specifically, but also the other endocrine deficiencies that are attributed to surgery. So in the last few minutes, I know I've gone over a little bit, but I want to talk about the cognitive aspects of radiotherapy. We've published quite a few articles over the years that included patients with craniopharyngioma. One of the most striking things was about 15 years ago when we saw how off the chart children were who had craniopharyngioma compared to patients with other tumor types, and this is attention testing. We also looked at behavior and the impact of behavior based on hormone deficiencies or other factors. We've also looked at verbal and visual auditory learning and some of the clinical factors involved in these patients. Most remain within the range of normal, and that's comforting, but there are patients who are outliers based on clinical conditions and treatment factors. And then finally, adaptive functioning, where socialization and communication seem to be affected in some patients more than others. So looking at the long-term cognitive measures of RT1, we now have data going out to 10 years on this cohort. And I've spent some time recently looking at intelligence, analysis, IQ or full-scale IQ, and then academic achievement, which is reading, math, and spelling. We see here that IQ declines significantly over time, but it always remains within the range of normal. So that's a bit comforting. We know that patients, based on their race or shunt status, their baseline can be significantly altered with this measure. And over time, younger children tend to have more problems. And so is this a reason to avoid radiotherapy? Maybe not specifically, but we do need to minimize dose to normal tissues. And so we've also found an association between radiation dose and different brain structures. And in this case, the temporal lobe, we need to limit the dose to normal tissues as much as we can. And this is why we use smaller target volumes and we use newer beams such as proton therapy. So we've done a lot of work, statistical analyses to look at the impact of clinical variables on outcome, and this is IQ in this case, where we show the impact of age. Older patients do better than younger patients. Race affects baseline, shunt status affects baseline, radiation dose affects trajectory as well. We've also looked at academic achievement, as I mentioned, reading, math, and spelling. We've developed models, and the upshot here is that shunt has a major impact on baseline academic scores. Here we're showing the spelling in this RT1 cohort, but also the impact of radiation dose and the impact of patient age. And so these models are very helpful because they can help us predict where patients are going to go after treatment and based on their clinical factors. So finally, the last thing I want to talk about is attainment of functional and social independence. This is just an article from the St. Jude Life Group. They've looked at brain tumor survivors, and they've looked at independent living, employment, ability to drive, personal relationships. And you can see that craniopharyngioma in this series is underrepresented, only included 7% in the series. And so we went back, and I worked with a medical student here at the University of Tennessee Health Science Center. We went back and looked at the RT1 cohort because they had pretty extended follow-up. And these are patients who were treated, again, average age was about 8 years. At time of assessment, about 25 years. And we've looked at their outcomes after radiotherapy. And one of the things that we found good things, and we found things that are a little bit troubling. From a living situation, almost 80% of these former patients are still living in the family home. I guess, is that expected or unexpected for a group that's about 24, 25 years old? We see stable social relations, both with adults and friendships. Parental marital status is about the same. And I think if you look at the right side of the slide here, what I found to be interesting is the number of patients who've been able to finish school, attend high school, attend college, or even those that go on to achieve advanced degrees. And when we look at employment, quite a few of these patients are still attending school, and this would be just a few finishing high school, a number in post-secondary education, but we also have a number who are gainfully employed and living independently. And then when we see here some of the complications long-term that these patients experience and that they're very concerned about, visual field deficits, these can affect patients over time, depending on which state you live in. That can affect your ability to get a driver's license. Diabetes insipidus seems to be a nuisance for many patients. Dealing with shunts long-term, sleep disorders, dyslipidemia, anxiety, depression, back pain, reflux, and even hearing problems to some extent. And so I think that we need to refine our assessment here and look at this very carefully, because we want to be able to present to patients and their parents an expectation of what might happen after radiotherapy. Obviously, this is radiotherapy using older methods, but I think the information itself is still important. So to wrap it up here, chronic conditions that we found related to health maintenance, obesity, symptoms and conditions, visual field deficits, and mental health. Patients do have some deficiencies, meaning age-appropriate academic, professional, and interpersonal markers. We think that early intervention is important, and we should be designing more trials to intervene here early on. And obviously, these patients need maximal support and encouragement from us and others. So I want to thank you and just recap. These are the long-term results from the RT1 protocol that show the excellent control rates and acceptable toxicity. We've identified some important prognostic factors. I think we've given you some very good numbers to look at, solid numbers that you can use in the consent process or evaluation and management process for patients. These numbers also provide excellent benchmarks to compare future treatments, now proton therapy, and this is something that we'll be doing in the next few years. We have more than 200 children now who've been treated with proton therapy. We can go back and compare them to the RT1 cohort and see how well they're doing, and we're excited to do that in the future. And then the results from these studies really support the need to focus on survivorship and minimize treatment-related complications. So again, thank you very much and appreciate the opportunity to speak today.
I want to thank you so much, Dr. Merchant, for what an amazing comprehensive talk and the really incredibly rich cohort and data that you presented. More than 100 individuals followed for more than 10 years. I mean, such amazing things that you guys have been able to learn, and I'm sure we'll continue to learn from this cohort. We've received some questions that I'm gonna start giving to you, and folks are welcome to continue to add to the Q&A. So the first actually is less a question, more a greeting from one listener who says, thank you for getting tumors under control, and she's doing well and she's happy to see you. So a personal greeting and thanks is a nice way to kick it off. The next question I think refers to the statement around the predominance of adamantinomatous subtype craniopharyngioma. This question is, Dr. Merchant, are you aware of any case studies of pediatric papillary subtype craniopharyngioma?
Well, we thought we had one about 2 years ago, and we had a visiting resident and he wrote it up and got it all ready. And then we did a little more detailed analysis and it turned out not to be papillary. So we just haven't seen that in all the patients that we see here. But it's important to note that we don't have tissue on everybody, right? Because there's a small cohort of patients, I would say 5%, that we treat without really any surgery. It's a growing tumor. We agree that the diagnosis is craniopharyngioma. Surgeons don't want to operate. And then the others where we treat with catheters and drain the cysts, we don't have tissue, so we just don't know. And this is going to make things a little difficult in the future when we do genetic testing on tumors. Is it really representative? Because if we only have tissue on 70% of our patients, and oftentimes that tissue is inadequate for genetic testing based on current methods, it's really hard to make advances.
That's a really interesting point, and in particular, like the importance of getting tissue. I'm aware, and I think our neuro-oncology colleagues may have a handful, or but case reportable, unusual to have the papillary subtype, but as you say, sometimes difficult to even know. The next question, there's two questions. I'll share both of them. One asks, or the first part, I think gets at, if this tumor is present, craniopharyngioma, and if it presents with cystic features, is that associated with adverse outcomes? You showed the overall survival, progression-free survival, event-free survival. Could you speak a little more to that? Then the second part of the question is, and I think refers to some of the data that you presented on salvage therapies, like what else is another type of radiation or chemotherapy ever given if you've already treated with proton and resection and still don't have the outcome you wish? So the first part speaks to cysts, and the second part to what happens when you've tried these methods and then you need to try something else.
Well, I like both questions, and the first question has to do really with what's called radiomics, right? So radiomics is when you look at the image, you can tell what is cyst and what is solid, but radiomics takes it in much more depth. And so the texture, size, shape of the tumor on imaging, does that give you some, can that predict what's going to happen after treatment? So we're working on that right now, in fact, doing radiomics on some of our patients to see if there's an association with disease control. And it's kind of a hard study to do because, the first imaging, the one that really shows the tumor well, sometimes it's done in a rushed fashion and the patient goes off to surgery. And so it's not like the best study, and there's motion. And so maybe not all patients can be assessed there. The other is that overall, compared to other brain tumors, the failure rate after radiation is so low that we don't have a lot of failures or events to use in our models. And so we initially looked at 100 of our patients, but we had to enrich it for failures by going out into some of our other series and pulling them in. So that's a great thing. And I think we will hopefully answer that question in the next year. And then the other question is about salvage therapy. It's not something that we like to talk about when we're meeting a patient for the first time, but it always comes up, right? And so families will say, well, what if this doesn't work? And I like to say, well, it's going to work. And that's, we're very positive that this is going to work. But in some patients, there is tumor progression. And if you're lucky, surgery can be done, and the surgery removes that portion of the tumor that's growing. Sometimes surgery removes that portion of the tumor that's growing, but we then see a little more growth, and we can apply high-dose radiation called radiosurgery for some cases, and for others, the progression is unrelenting and invasive, and there's not a good outcome. We've tried different drugs. Others have tried different drugs. We've just not been successful. And this is why we need to take the tissue that we have and use a next generation sequencing to look at potential targets. And I think hopefully in the next couple of years, we can come up with something. If there were a treatment better than radiation therapy, I would be all for it. And I think we all need to work together, as you said earlier today, to come up with solutions that help everyone.
Absolutely, totally agree. Bit of a different line of questioning. This questioner asks, she knows that St. Jude's is a children's hospital, so these studies are done in children. She's wondering, what about the adults? Are there places that do this type of radiation on adults? Would the results be as good? This questioner had her tumor 15 years ago as a child, but she knows it could come back, and she would like to know more about options. So speaking to the adult data a little bit, or if such data exist.
I think the adult craniopharyngioma, it's so rare, and it happens in very old patients. And I get called periodically about an adult case and what to do. And, they operate on these patients. I think it's promising that those are typically the papillary subtype. And if they have the certain mutations, they can be targeted with agents that are currently available. I just don't know. It's such a rare tumor to begin with.
Yeah, makes sense. This is a question about shunts, a very specific question. When you talk about shunts, and you showed us a lot of interesting data about outcomes that stratify by shunt, does this include Omayas?
No, it doesn't. So a shunt is really is a last resort to divert the cerebrospinal fluid. And as I mentioned, in our RT1 series, there are 27 patients out of 100 that ended up with a shunt. There are many more that had hydrocephalus. I've looked at our more recent series, and the incidence of permanent shunting is lower. So that's a good thing. But putting a catheter in to assist with the reservoir attached, that is not a shunt.
Got it. Thank you. The next question asks, could you speak a little more about the sleep studies that you've done at St. Jude's and where the questioner can find more information about sleep studies and the results of sleep type testing?
So this is an area that we recognized a few years ago that's very important to optimize patients with craniopharyngioma, amongst other things, right? There's so many different things to work on. And so we were fortunate enough to put sleep studies in at baseline. We would then do the NAP study, if you will, at 18 months. And then at 3 years, we would repeat the full-blown polysomnography, sleep study. And so we found this is really a great way to identify excessive daytime sleepiness and patients who really could benefit from some of the medications that are available to improve both their attention during the day, but just overall sleep and health at night. And I had wanted to, and obviously we could talk for hours, right, about craniopharyngioma and things that we see. So I saw a patient this past week who completed radiation about 4 months ago. And at the end of treatment, we said, look, you need CPAP. You really have obstructive sleep apnea. Your sleep is terrible. You're hypoxic at night. You feel terrible during the day. Please, please, please. And so they went home and they were not compliant and they didn't get the CPAP started. And on the first brain MRI after radiation therapy, there were changes in the brain, and they were not anywhere near the field of radiation. And so this was really obvious. MRIs have become so sensitive, they identified the impact of obstructive sleep apnea in this patient. And so then they went back and he very aggressively used his CPAP, and he came back for an MRI last week, and that imaging change had cleared. And so the power of good sleep, good oxygenation, getting it right, I'm so convinced, and I've seen other patients who've had similar things happen. So sleep is very important. And I think assessment of sleep needs to be a part of a package, and that package also is the nutrition and management of hypothalamic obesity, if it's there, and all the other things. So I think in our next series of studies, we have to be more comprehensive and follow an algorithm that takes patients based on the risk factors. And I think the RT1 data that I showed you today will be helpful because we can say who's at risk for this, who's at risk for that. And we do have some sleep data on the RT1s, but we haven't much more on the RT2 and RT3, our more recent studies. And I think that's going to be a burgeoning area of not just research, but actually gain for our patients.
Well, I couldn't agree more. The inaugural patient conference we had, Amy will remember, we had a colleague from our sleep medicine department talk about her experience and how important that is. So I appreciate those comments. The next question we have, I would like to know the answer to this one, Dr. Merchant. It's going to be a challenging one. At what point after proton radiation can you feel reassured that radiation has worked and tumor regrowth is unlikely? Like, when are you out of the woods? You showed us data about what happens at 5 years, but you must get that question often.
Yeah, well, so when we design a clinical trial, because cyst fluctuation is so common after radiation therapy, you can't really call someone progressive during the first 1, 2, maybe even 3 years, right? Unless the solid part of the tumor is growing. And so when you look at the survival curves, you really don't see very many events during that first period of time. So this begs the question, why are we doing all these MRIs? Well, you're doing the MRIs because if there is a lot of change and the patient could be hurt by it, specifically their vision, I think we need to keep an eye on that. But maybe there is rationale for dropping the number of MRIs that we do, and we've done that to some extent. So the RT1 data showed that the median time to progression was 5 years. And so I think is that concerning? Well, it's 5 years. I mean, that's what the data showed. It's 100 patients followed for a median of 15 years. And so when we see progressions, typically 3.5 to 5 years after treatment. Most other types of brain tumors, 80% of the recurrences happen within the first 2 to 3 years after treatment. This is a very slow growing tumor. But I think based on the amount of tumor, the type of tumor, this radiomic information that we can come up with, I think we can be more accurate on when someone might progress and follow them in a more tailored manner.
That's terrific. We have lots of questions coming through. We only have a few minutes left, so I'm going to do my best. I know we may not get to all of them, but this next one I think would be great to have your input on. This question asks, is age generally considered not to be much of a factor? What about your methodology makes it safer to use on very young children, such as those under 3 years of age? So in the risk factor data that you showed us, or stratification with respect to outcomes, can you tell us more about the effect of age? I think you spoke a little bit to it, but this questioner is curious specifically in toddlers.
So we didn't have time to go over this, but when we do what's are called multivariable models, multivariable analysis, age is significant, but so is radiation dose. And so by combining those two, we look at those factors specifically and see which one has more weight. And so that's radiation dose has a major weight in the direction that the beams are pointed and how much dose is given to not just the temporal lobes, but the hippocampus. It's a very complex thing. And then also the fact, the demographics and the tumor volumes and things like that. So we always tell patients that younger patients are likely to have more problems than older patients. This is what we've seen in the historic series. But I think the patients that we treat now, because we're optimizing so many other things, it's much more promising. And I can tell you 3-year-olds and 4-year-olds that are getting radiotherapy now, 6-10 years later, they look very good. And so, knock on wood, we're very happy with our results to date. And I hope we can report something for you in the coming year.
I think we have time for one more, and we're getting so many in the chat. I'm trying to choose one of general interest, but they're all terrific. One, maybe just give you an opportunity to speak a little bit more about the volume at proton therapy versus surgery. So the question specifically asks, are there any relationships between the factors you observed? This is another radiomics discussion potentially to be correlated with long-term outcomes. Like, what's causing the effect of tumor volume? Is there any difference between volume at the radiation treatment versus surgery? And in this example, this question says that my son had radiation treatment after the original resection because of an almost immediate recurrence and without a second surgery. So maybe speaking to the volume question of how that affects outcomes in surgical versus radiation treatment scenarios.
Right. So this is complex, obviously, and I hate to say this, but if someone goes undiagnosed, their tumor is going to be bigger and they're going to be hurt more, right? Is that typically the younger patient? It could be, because the symptoms go unrecognized or not able to describe to their parents what's happening. So that tumor volume question at diagnosis is really something that's complex. The impact of surgery. So when you have 100 patients and they have 197 different tumor-directed surgeries, it's hard to do statistics, right? So where do we start? And where we start is and I worked with one of the neurosurgeons here. And if you basically take everyone's op notes and you lay them out on the floor and you line them up in rank order of complexity and invasiveness, you can figure out who had a little and who had a lot. And it's finding that cut point. There's when is there too much surgery and when is there not enough? We just don't have enough patients, even though we have 100 to address that question. And so what we need to do is combine that with the other 200 patients we have and start looking at who had no surgery, who had just a catheter. Was a catheter done in a stereotactic procedure, or was it done openly? Did they have one craniotomy? And this gets to the question, did they have two craniotomies? And then when they did the surgery, did they dissect to the point that diabetes insipidus developed? These are all the things that we need lots of patients to address. And maybe we need to combine our data from various institutions to come up with that so that we can tailor the approach, at least with the treatments that we currently have.
I think that call to even enhance the large data set that you already have, or the large data sets you already have, is a great way to wrap up the session, as are, we didn't get to all of the really terrific questions that kept coming in, and speaks to the degree of interest that your talk generated. So thank you so much. And you have some additional greetings and thank yous and hellos that I'll let you check out in the chat from folks. Nice to see those connections. Thank you again so much, Dr. Merchant, for coming with us. And I'll remind the group the breakout sessions start again at 2 o'clock. So you have a bit of a break for lunch. All right. Everyone, thank you so much. Thanks again, Dr. Merchant.